Well, good afternoon. Whoa, it's loud. I think we'll go ahead and get started. All right. Great. Well, thank you, everybody. So, I am Sarah Dash, and I'm President and CEO of the Alliance for Health Policy. And it's a real privilege to be here this afternoon, and we have a really fantastic panel to comment on the important issues around children's health that we've been talking about today. And we have the job of keeping you all enlivened and informed after you just ate lunch, so we will do our best to do that. I just want to say on kind of a personal note, it's really, I'm so glad to be back here in West Virginia. It's really a privilege, and some of you might know I started off, I was a kind of a consultant for the state over 10 years ago and had the privilege to work with many of you, and I wasn't even from New York, I was from New Jersey. And they told me that, a lot of people would ask about, kind of where I was from in West Virginia, and I couldn't answer that, so I felt a little self-conscious, but everyone here has always made me feel so welcome, and it always feels like coming home to be here. It really does, and so I really appreciate it, and I want to thank Rocky Goodwin for including me in the planning of this program, and I want to thank Senator Rockefeller first for allowing me the privilege of working for you in the Senate, and for having the vision to found the Alliance for Health Policy, and as the Senator said earlier, we are committed to being a nonpartisan, fact-based resource for federal policymakers, and we do hold a number of events for congressional staff, for members of Congress, for the media, and for the broader health policy community. And if you are here in West Virginia and you want to know more about our programming, I'll just put in a small plug that you can sign up for our listserv at allhealthpolicy.org, and we'll send you lots of emails, but not too many. And everything we do is videotaped, and a transcript is always made available. So if you want to find out what we're providing to the federal policymakers in DC, you can sign up, and we'll actually have a briefing this Friday on insurance market stabilization. So another very important topic that's being discussed today. So today this panel is here to talk about bright spots and challenges in children's health, and we've heard a lot about the importance of good policymaking for children's health, and a lot about the history behind the legislation and implementation of the CHIP program. So we're excited to be talking today about kind of where we are right now, both in terms of coverage for children and also in terms of just the broader state of children's health and kind of where we go from here. We have a really wonderful panel, and what I'm going to do is introduce them, and we're going to have kind of an interactive panel. And so without further ado, let me introduce from all the way on my left, Joan Unger, who is the Executive Director of the Center for Children and Families and a research professor at the Georgetown University McCourt School of Public Policy. And she's a national expert on Medicaid and CHIP and children's health coverage. Next is Dr. Christopher Pine, who is an Eberly Professor of Outstanding Public Service at West Virginia University, and served as chair of the Department of Public Administration from 2004 to 2011, and also serves as Associate Dean for WVU's Eberly College of Arts and Sciences. And next is Dr. Catherine Moffett, who is a pediatric infectious disease specialist in Morgantown and received her medical degree from Penn State College of Medicine, has been in practice for more than 20 years, and has a special focus on children with special needs. Finally, and of course last but not least, we're thrilled to have here Senator Roman Prezioso, who represents the 13th Senatorial District in West Virginia and has chaired the Finance Committee for the last 20 years. And in addition to serving on a wide range of committees, including Health and Human Resources, he was first elected to the House of Delegates in 1988. So thank you, and thank you all for being here. And I'm going to kick it off by asking each of you to spend maybe 3 to 5 minutes sharing your perspective on the overview of where do you see the bright spots in children's health, And where do you see the challenges from a broad level, and particularly as it relates to rural Appalachia and to the challenges we face here in West Virginia? And I'll let Joan start if that's all right.
Sure. Well, thank you, and it's just such a privilege for me to be here. I'm going to note, so everybody knows, I just was on a 3-week vacation, which was like the longest vacation I think I've ever had, but after the ACA debate, it was needed. And so I came back, and as some folks at the reception know, if you were there last night, I was like in this really positive mood. This CHIP's going to happen, it's all going to work out fine, and various things have happened in the last 20 hours that have already started to undermine my mood. But I'm gonna try to leave that aside. And I wanted to step back. Just this has been such a wonderful event for me because I worked in Washington on CHIP when it first passed. In fact, I was pregnant, my daughter is now a sophomore in college. So the 20th anniversary is pretty amazing. Pretty amazing that we've had CHIP this long, because I can remember before we had CHIP. And what has been so remarkable, and I think particularly in the troubled times that we find ourselves in, is that we have really, I think as a country, something to be very proud of. And I know you talked a little bit about this morning, but I really want to emphasize that over time, between the Medicaid expansions of the 1980s that were championed by Congressman Henry Waxman, through the passage of CHIP, and what CHIP really did was it stimulated attention and interest and focus on not only doing outreach to families who now had a new coverage option, but it also stimulated an enormous amount of work that our center and many of you and others around the country have been involved in, people like Sharon, to streamline enrollment, to ensure that kids stayed on. A lot of times we see kids churn off, so renewals are an enormously important issue. So all those kinds of, we call it the reducing red tape, right? So, and the way I think about it is, do you come to your job with, say you work in an agency that's processing applications for kids coverage, are you hearing from your leadership that your job is to get the kid covered or not? I mean, or are you hearing, we have to check this, we need this paper, we need that paper, we have to turn them down. And so there really was, stimulated by CHIP, even though the vast majority of children are covered in Medicaid, CHIP spawned this enormous interest and bipartisan support for covering children, and just allowed good things to happen to the Medicaid program as well. And as a result, we now have 95% of children covered in this country, which I think is phenomenal. And the public does not realize this. We did a poll right before the election, and most people think, it was about 50% thought the number of uninsured children was going up. But it's been going down for many years. And you all here in West Virginia should be especially proud, because as you know, you're at 97%. And I know it's not too often that West Virginia perhaps finds itself at the top of the rankings. But it speaks to the incredible work that so many of you have been engaged in, and I think it's really exciting. I always point out, Alabama is another huge success story. Alabama is the star of the South in covering children. They also have about a 97% coverage rate. So that surprises people, because when you think about it, you think, oh, Massachusetts, they're probably doing really well. And yes, they are, but we have states all across the country that have really taken this to heart. And I think in these troubled times, when we have such a need to find issues that unite us, that children's health really can be that issue. And just two more things I want to say about that. Coverage matters. Now, I know that you may not feel great about where kids and families are in West Virginia with respect to their health, and there is so much more work to be done. And we certainly, at our center, we were hoping that we could really pivot to dive into all these questions about quality of care and organizing care better. Unfortunately, since the election, we've had to move to a pretty defensive posture, but hopefully we can get back to that, because we've made so much progress on the coverage agenda. But we know, and there's more and more research, and Secretary Burwell alluded to some of this morning, longitudinal research, because we had those Medicaid expansions in the 80s. All kinds of studies are coming out, and they're showing 3 buckets of benefits for kids who were exposed to Medicaid as opposed to being uninsured. Their health is better, both at the time and even when they become adults. They stay in school longer. They're more likely to graduate from high school and even attend college. And they have better economic outcomes, which results in a really strong return on government investment. Because their wages are higher, they're paying more taxes, they're using fewer public benefits. So it's a triple win. We've got lots of good research to show that. We actually did a report you can find on our website that kind of summarizes all these studies from peer-reviewed journals. So I encourage you to check that out. So coverage is really important. It's not enough, but it's critical. So, so we've come to this point in our country where we should be celebrating this, building on this, seeing how we can take it further. And of course, we found ourselves this year with respect to the Medicaid program in a very defensive posture with over $800 billion of cuts being proposed and a cap. And this was not unexpected, and I think one of the things that really caught my attention, we were very engaged in doing a lot of reports and other things explaining the role of the Medicaid program. But for months, it felt like children, nobody was talking about children, okay? ACA repeal, first of all, was mostly about the marketplace and not much about Medicaid. And then when there was discussion about Medicaid, it was about the Medicaid expansion and should it be repealed or not. No discussion about this cap, which was a fundamental change to the financing structure of a program that's been operating for over 50 years. And children, as you know, over 1/3 of children in this country are on the Medicaid program, and for children 0 to 5, it's even higher. In some places, we're getting up to half of kids in those critical developmental years, 0 to 5, are on the Medicaid program. So it was frustrating that none of that was really even being discussed, because capping the Medicaid program was not actually technically anything to do with repealing the ACA, right? That was just something that was moving forward while they're in the neighborhood. But I think we had a real breakthrough in the last couple of months of the debate on the kids' piece. And I have to say, there are so many parents, particularly, and I know I'm going on too long, Sarah, but see, you've caught me in a reflective moment after I've just been on vacation thinking about the year. Particularly parents of kids with disabilities who brought their kids to Washington. I don't know if anybody followed the Little Lobbyists on Twitter. Did people follow that? Amazing. Really disabled kids. I mean, these parents are just phenomenal. But more and more discussions started emerging about kids. We did a report on the role of Medicaid in rural areas for children. Medicaid is disproportionately important to them in rural areas, and that got a lot of attention. So we started to see more and more discussion about children, and that, I think, was really important to change the tenor of the debate about Medicaid as the debate went forward. So I guess my point is that children are, I think, a really important way for us to try to break down this partisan divide. As we heard, we should remain hopeful about that, and I hope, particularly on CHIP, as we go forward, we'll talk more about that. That's an opportunity to do so. I'm sorry I went over.
Thank you. Why don't we go right down the row? So, Dr. Pine.
Good afternoon. How's everybody? Great. You can hear me now, can't you? So I just said, how is everybody, and good afternoon. Okay. Let me put some stuff into context here for just a moment, because I think it's important. One of the things that we've heard in this conference today are many different perspectives from many different disciplines. So I'm a political scientist, but I study public administration, and I've also done some administration. Just to clarify my biography, I was an associate dean. Now I'm joyfully a faculty member and enjoying that work. And that work has allowed me to look at health policy at the state level as well as the national level. And we're sort of in that stage of the day where we're trying to pull together the different threads and weave together a narrative that's informed by empirical research, a narrative that's informed by experience. And so here are three things I think we should keep in mind as we talk about bright spots and challenges in healthcare for kids, not only in West Virginia, not only in Appalachia, but indeed across our country. One is, I invite everybody to think about underlying conditions. And definitely there are some bright spots there. Definitely there are some bright spots there, because we've seen how children's health has improved in our state over time. You've witnessed that this morning. But we also know that there are challenges with those underlying conditions, and so we need to keep those in mind. Second, we need to think about healthcare infrastructure. I could not agree more with Joan that coverage is absolutely essential. But with coverage comes something else, and that's access. Right, Sharon? It's access. And so when we talk about bright spots and we talk about challenges, and I know that we'll have more time to talk about this in a little bit, we want to talk about access as well. What is our infrastructure doing to provide care for kids in terms of primary care delivery, in terms of specialty care delivery, in terms of working with kids who might need just the most basic services, but also those kids who might need more complex services because of complex healthcare conditions or chronic healthcare conditions. We have to be aware of that. We constantly have to be aware of health disparities. So when we talk about healthcare infrastructure, we need to talk about the delivery system. Remarks by the Secretary echoed and reinforced that. We also have to consider the system of actually reaching out to kids and keeping them enrolled. Definitely a bright spot is that 97% level, isn't it? Absolutely. So once you hit 97%, you can't take things for granted. And as Joan has just said, how do you make certain that kids keep connected to the system? It's easier said than done. And as the state senator from Pennsylvania said, deciding is difficult enough. I know that the senator realizes that. But what's really tough is the hard work of implementation and improving processes in order to minimize what the economists would call transaction cost to accessing healthcare coverage and accessing healthcare. And the third thing that I think we should keep in mind are outcomes. And we've had some conversation about that today. And our outcomes might be the outcomes that I would anticipate that Professor Moffitt might be talking about, those real world results for individuals, but also policy outcomes, how we're making a better infrastructure, a legal, political, practical, economic infrastructure to help children. So I would invite you all, as we think about bright spots and challenges, to keep those three things in mind: underlying conditions, healthcare infrastructure, and outcomes. I think it helps us to organize our thoughts. As a resource, I think it's important for us to take into consideration some recent research that has been done here in Appalachia. Just a few weeks ago, the Appalachian Regional Commission issued a report called Creating a Culture of Health in Appalachia. I think it's required reading. Those of you who have spent time in West Virginia, which I've certainly had the honor to do, realize that there's a lot of resilience in our state. There's a lot of ability in our state. But there are also wide areas of health disparities, concerns about chronic health conditions. This report from the ARC, I think, helps to give a good, broad illustration of some of the issues that are facing our state and the entire region. Certainly, folks will want to quibble over the findings and the methodology. That's what we do in academics, right? But the big message is this, is that while there have been some improvements in healthcare status and indicators, there are also a lot of challenges. So one takeaway is that I would encourage folks to take a look at that ARC report, to get a broad brush view of what's happening in Appalachia, to help us understand some of those underlying conditions. Because mind you, any success that we have on the surface, below are dangerous undertows and undercurrents of challenge. The gains that we make are gains that have to be preserved. We can celebrate where we are. We've talked a great deal today about the political environment. In my remarks in this panel, I'd like to talk more about the administrative environment and some of the tools and resources that we can have and utilize to improve coverage, but also to improve access. Thanks, Sarah.
Thank you, Dr. Moffitt.
Thank you. Good afternoon. Thanks for having me. So I'm one of the lone medical people. We did hear from Mariella, who's a nurse, earlier today, but I think I'm the only really clinical person here on the panel, at least today. And I am a pediatric infectious disease specialist. I've lived in West Virginia and worked here in Morgantown for almost 20 years. I am a native New Yorker, but from Western New York, not the great city of New York, but I've made West Virginia my home, and there's many reasons why this is my home. I'm proud to be a Mountaineer. I've raised my children here. My husband also works at WVU, and we love the people who we work with. We love our patients. And probably I should move the patients to the top. It's a privilege to take care of children, and it's a privilege in West Virginia to take care of children. They come to us appreciative. They don't come for a third and fourth opinion, but they're very grateful that we help them. And it's a very nice environment to work. And they think this is coming to the big city of coming to Morgantown. So I love my patients. I've seen my patients grow up into young adults. And the success I now taking care of cystic fibrosis patients is that we have to have an adult center. Because when I was a medical student, CF patients didn't live to adulthood, and now they do, and now almost half of our patients are adults. So I take care of a chronic disease where it is imperative that they have coverage, and I'll just share a couple stories. I was reflecting on, I have a little guy, I'm gonna call him Jay, and he is 13, and he lives in Buchanan, and has a wonderful family. I think he was about 2 when I diagnosed him with CF. And he has an older sister who now is out of the household, and when their family went from 4 to 3 people, he's been at jeopardy now for losing his health care. I did look up, and their family income is somewhere, it was checked, between $30,000 and $39,000 a year. Okay, some people spend that much on tuition for a semester at a private college, not WVU. Put that in perspective, and this family worries greatly that if Dad gets a little overtime, he may not have coverage. I have another set of brothers who both have CF, and they have some other siblings, and when their father got a promotion and got a little extra pay, then some of their supplements, because CF needs to be on a high-calorie diet, they were in jeopardy of losing those. Those may sound trivial, but those are not trivial things to our kids who have a chronic life-shortening disease. And yet, when you step back and look at the big perspective of what we're able to do in our department here, I can speak for WVU, I took over a center that was last in the nation for CF, for pediatrics, and we're, out of 160 centers, I'm proud to say we're at the top. Some of our measures are top 10 in the nation. We can do it, boots on the ground, day to day, taking care of our patients. There are successes in this room. Bill Neal talked about his cardiac project. The neonatal, we saw the infant mortality in West Virginia has gone down. There's still room to go. The neurology clinics, I see people around here. So we're there day to day. But we have a lot of challenges. And the other last thing I will talk about is I'm a big advocate for vaccinations. And people who know me probably know this about me. So Senator Rockefeller mentioned going and doing pap smears on women and delivering the news of cervical cancer perhaps to these women. Well, unfortunately, West Virginia is #1 in cervical cancer deaths in the United States. But you know what? We have a vaccine to prevent cervical cancer. And yet our rates are really not good of vaccinating our boys and our girls. I know boys they get other HPV-related cancers. Our toddlers are almost last in the nation for vaccine rates in West Virginia. Now, the bright spot is that once they start school, we are at the top of vaccine rates because we have very strong laws that I'm so appreciative, and there's several others in the audience, that we keep strong. So we can't give up the need for access for these kids to get coverage, to get to primary care. Those babies need to be on time with their vaccines. We need to vaccinate our girls and our boys to prevent cancer and all those other diseases. I've taken care of all those vaccine preventable diseases. It's not fun to have a baby with whooping cough or a child who's losing their whole shoulder from the flesh-eating disease, from a complication of chickenpox. They're not benign diseases. So as an advocate, we as pediatricians, we're advocates. I'd love to hear from the policy people here, how can we do a better job? How can I do a better job to get the message out? We write op-eds, we call, we email. I do make a trip down to try and lobby a little in Charleston when they're in session. What else do you need from us? We're educators, we have our medical students, residents. What else can we do for the children? Because we're very willing to help in any way we can. So thanks.
Thank you, Dr. Moffett, and I will say, to your clinical experience, you know, I always appreciated the clinical work that pediatricians do, and then when my own son escaped from the examining room 4 times because he didn't want his shots, I appreciated it even more. So he did get the shots, though. Thank you. So we will move on now to Senator Prezioso.
Sarah, thank you. The hazards of going last, I categorically check everything off that everybody said, and so goes my speech. And I've written over most of it, but I would first of all like to thank Senator Rockefeller for the influence that he's had, not only on the state of West Virginia, but also as my tenure as chair of the Health Committee. You were very influential, whether you knew it or not. We were listening to you and looking for your guidance, and a lot of the things that you established, we tried to emulate. And we did a lot of good things, and we're looking at the bright spots and challenges. Just received, I'm on the Oversight Committee for Health and Human Resources, and I've followed very closely the statistics, because the empirical evidence that I receive is so important for me to make good decisions, sometimes in light of political parties and political philosophies. You know, if you have the facts before you and you can argue those, I think you're further ahead. And as we look at our CHIPS program, we see that 21,000 of our children were enrolled in CHIPS, and 188 children were enrolled in Medicaid. But still, we have about 11,600 children in West Virginia that aren't covered by insurance. And we still have work to do. The bright spot is, yes, we've got 97% covered, but there's still the folks out there that we still have a lot of work to do. As I look at a practical perspective from a legislator, and I'm a retired public school administrator, so I see firsthand the effects of healthy children in schools. And the evidence is very clear. If you can teach a young young student to read, keep them on grade level by 3rd grade, their chances of graduating and going on to higher education are dramatically increased. But if you can't get a student on grade level by grade 3, chances of graduating from high school are pretty good. And it's the same thing that I see with children in our school system. If they're not healthy, if they don't have good nutrition, they can't function in a classroom, and that further impairs their education possibilities. So our challenges go beyond just health care and the things we can do in the Health Committee. I also chair the Education Committee, and I see firsthand that those correlations between education and health care are so dramatic. And I've seen over the years a sort of a paradigm shift. The cost of education, increases. The cost of health care dramatically increases. So what do you do as a state legislator on a limited budget when you've got a mandate to fund in your Constitution public education? Also, morally, you have a mandate. And I don't think there's a legislator here that doesn't want to see any of our children without proper health care. But I've seen that paradigm shift where tremendous amounts of money are now going to health care and are taken away from our education system. Both are so important, and we have to look at it sort of systematically when we make these decisions. So as a legislator, what do? I chair the Finance Committee. And about 7 years ago, when I had the responsibility to put a budget together, I began to see, we were doing 6-year studies, and we could see about 6 years into the future, you know, what our costs are going to be in health care. We have all the experts that can you know, put those figures together for us. I can see that, you know, we've got a cost of living coming in. People need pay raises, teachers, public employees. And when you see this 6-year perspective, and then you see the revenues that are coming in, our coal industry began to take a hit, you know, environmentally, regulation-wise. That was trending down, and as the cost trended up, we were getting into a very serious situation. And I could remember time and time again standing up on the floor of the Senate and saying, guys, we got to tighten our belt. You know, the worst is yet to come. We didn't know how bad it was going to be, but, you know, it's here now. We've got some tremendous deficit problems. It's just the way the situation is. And I wrote down some statistics. I know that most of the things have been quoted, but in the year 2000, West Virginia spent about $350 million of general revenue dollars for Medicaid. In 2017, not even 10 years, we doubled that. $600 million is being spent. So if that trend line continues, you can see where we're going if things stay the same. So the challenge to state legislators are very simple. We're very dependent on what the federal government does. That has a tremendous impact on what we do. And, you know, if the reauthorization for Medicaid and CHIPS and healthcare doesn't get reappropriated, we're looking at a very tremendous deficit in our state budget. And the only way you can run a budget, and each of you have your own personal finances. What do you do when you get in a bind? You cut something out that you don't need, or something that you may need but you can't afford. Or you go out and get a part-time job. Well, it's no different for us in the state. We've got debits and credits, and we've got to meet our bills, but we're in a situation now where we've got to enhance some revenues to get through this tough time. There's no way around it. And I've been through this one time in 1989, and for all practical purposes, the state of West Virginia was bankrupt. Then Governor Caperton came in with a new approach. We went into a special session in December. We generally go in December, but we went in December and we raised $350 million in taxes. I thought, boy, this is the shortest political career in West Virginia history. I mean, you can't go out and raise taxes. The tax word is just don't touch it. But we got through that. We raised taxes. We put ourselves back on financial stability. Since then, we've eliminated each one of those taxes, and we're in the situation we are now. So we're going to have to do something to enhance the taxes, because we've got healthcare costs, you know, in the future. We have declining revenues, but also we have this horrendous drug problem. And the problem that's causing us is just beyond comparing. Mental health and things of that sort. And the children that are being born now that are addicted is just phenomenal. And we've got these additional costs that we've got to take into consideration. And I'm glad you mentioned the immunization program, because it's under attack in West Virginia right now. We have folks coming in and say, we don't want our children immunized. And you know, we fought very hard to protect that. And I hope we continue to do those things. But you know, getting back from a legislative perspective, we can't do it all. You know, we can recognize very clearly what the problems are, what the finances are going to be, what revenues we need to meet our debts and things of that sort. But, you know, it comes back to the education and personal responsibility and things of that sort. You know, we have to take into consideration, and I know I'm the tobacco tax antichrist. I mean, if they could eliminate me, they'd do it in a heartbeat. I think I've introduced every anti-tobacco bill for the last 20 years that's been introduced in the legislature. You know, and statistics clearly prove that when you raise the cost of tobacco, you increase your revenues. Now, how does that work? And on the other hand, you eliminate utilization. So it's a win-win. You know, last year we wanted to put $1 on. We fought tooth and nail to put $1 on an additional $1 on a pack of cigarettes. We got 50 cents. That's the only line item that we're seeing increases, but we haven't made a dent in it. And as I see statistics for pregnant women who endanger, you know, their children by smoking, it just totally amazes me. So we have to somehow get personal responsibility into the equation. You know, we've tried that before. A couple of years ago, we devised a new Medicaid program, that, you know, recipients had to sign up and they got additional benefits, and we were fought on that. I mean, we had to scrap that program. And Senator, I just want to tell you that a lot of people in this room were responsible before the Affordable Care Act was passed by Congress, that we had hired a Dr. Ken Thorpe from Emory University. And I don't know if you ever met Ken Thorpe, but he was giving advice to Congress and the Finance Committee or some committee. Well, anyhow, the state hired Ken Thorpe to come up and give us a roadmap to health. And some of the things that were brought to our attention, we wanted to increase the age of insurance for children up to 21 so they could stay at home, be in college, and still be insured, and we passed that. And we also came up with the medical home idea where we wanted recipients to, you know, find a home that they can receive those yearly checkups and things of that sort. So it was difficult. We thought we had the roadmap to health, but the very people that we were trying to help were fighting us. So I think it's imperative that as legislators, you not only educate us, which you have, and everyone at this table, I think I've talked to one time or another, and many of you out there I've talked to, but we've got to go out to the people that need the services and educate them too. I think that's important. Education is key, and being an educator, I can see it firsthand. And I just want to thank you for allowing me to be on this prestigious panel. I've learned so much today. Thank you.
Well, thank you all for those really thoughtful remarks. I want to start off by kind of trying to combine a few of the things that we've heard, and then we will open it up to the audience for some question and discussion after a little more discussion on the panel. So, Senator Prezioso, you laid out some of the very real budgetary challenges and the need to prioritize among very worthy programs from healthcare to education. You also talked about the link between some of those programs. And what I'd like to ask, and maybe you could start and maybe the other panelists could comment, is we're talking about the right way to invest funds. And how do you make decisions about those investments, and how can evidence inform those kinds of decisions about sort of, you know, we heard earlier about, you know, investments in children's health paying off in the long run, but then, you know, you mentioned kind of a 6-year budget window that maybe that doesn't always match kind of the return on investment. So how do you kind of square that circle, and how do you think about those issues?
When I was chair of the Finance Committee, the first thing you had to do was meet the requirements for programs that were mandated. And a lot of our code dictates where money should be spent, but also the court systems in our state dictate where the money should be spent. So you, first of all, about 65% of the state budget you can't touch. It's very difficult to get around it unless you have a statute change. The other 35% would be the low-hanging fruit, and higher education has been the recipient of that. You know, they're not mandated by the Constitution. They have a tremendous budget, so it's an easy target to look at. Some of the other things like state police and our judicial system, where we house our criminals, those aren't mandated, so you really can't cut those. You're very limited in the amount of money that you can cut, and that wherein lies the program. So if you have good ideas that need to be funded, you've got to increase revenues, and there are several ways to do that. Obviously, the cigarette tax is an easy way to do it. You know, I'm just throwing these out for your discussion purposes. But obviously, you know, we eliminated the food tax. It was at 6%. You know, some of us thought that, man, just put 2% back on the food tax. You know, and I know it's a regressive tax, but we've got to get through this thing to, you know, enhance our revenues. The pop tax, the sugar tax, and things of that sort. You're fighting powerful lobbyist groups. You're fighting political philosophies and things of that sort. You know, the empirical evidence that people provide us, which I depend on, I don't make a decision unless I have the facts. They called me the chairmanator when I was chair of finance, because everybody that came in with an idea, I said no the first time. They were persistent the second time, maybe a no. The third time, if they had a good idea, it was yes. But you had to fund that. So in order to fund that, if I couldn't enhance additional revenues, I've got to go back into my existing budget and cut something out. And when you do that, you're going to hurt somebody. And in this session, we've seen a bare bones budget. And I know it's based on the line of political philosophies that there's too much government. But, okay, we got to this point. Now we're going into next year's session. We're already predicting a $200 million deficit. That's a conservative estimate. We're getting a little bump in coal right now because Australia had a hurricane down there and the ports were devastated and they couldn't ship their coal out, so they came to West Virginia and they're buying our coal. That's not going to last long. I mean, Australia's not going to not rebuild and, you know, enhance their economy. So I don't know how much longer this little bump that we're getting is going to last. And you can talk about regulation, and it has a certain effect. But if I'm a businessman and I'm running the power plant right down the river down here, and I can buy coal for X amount of dollars, and I can buy gas for X amount of dollars, and the gas is cheaper, I'm a businessman. What am I going to burn? I'm going to burn the gas. So that's the problem. We have an abundance of gas right now that hasn't even been harvested. And that was one of the problems that we got into. You know, we sort of predicted the demise of the coal industry and the influx of the gas industry. The only thing that we didn't predict, that gas was going for $2 a thousand cubic feet. So take 5% of a ton of coal, which was about $100, and 5% of 1,000 cubic feet, which is $2, you know, there's where our problem is. We're not supplanting the amount of money that we're getting with the abundance of gas that we did with coal. So,
A comment?
certainly.
Yeah. So I think it's really important for us to understand that we live in an environment of scarcity, but we also have an abundance of ideas. And I think that one of the things that we recognize and we realize, and I'm coming back to the issue of healthcare and children and CHIP, is that we can find efficiencies, we can find effectiveness. So we do have issues of scarcity at the state level, and I think that's so crucial for us to understand and to appreciate, and that we have to be very, very mindful when we do new initiatives. At the same time, I think we have the creativity to realize that at both the state level and the federal level, there are pathways to innovation. It's amazing that West Virginia has made the gains that it's made with the scarcity of resources that we've had. And I'd just like to focus on just 3 examples. One, dealing with CHIP. In what CHIP did, Sharon, you will remember this very well. In the first years of CHIP, and you talked about it this morning, it took a while for momentum to build. It took a while for take-up to start to be realized. And I remember having conversations with you about this almost 20 years ago. And one of the things that West Virginia and other states did is they tried to smooth that process that Joan was talking about. Continuous eligibility, presumptive eligibility, to help to get those numbers up. Not costing a whole lot more, but being more effective. The second thing that I would emphasize to you all is this. Think about Medicaid expansion in West Virginia. Medicaid and CHIP. Medicaid expansion is the main narrative of the Affordable Care Act. And this is the point I want to drive home to everybody. West Virginia started at a different starting point than the other states in expanding Medicaid. Our neighbors in Maryland, our neighbors in Massachusetts and elsewhere had already expanded their Medicaid programs per se, quite significantly. West Virginia hadn't. And so what West Virginia did in expanding Medicaid is that we had to close a lot of ground, much more ground than other states. And we've done it pretty effectively. We've done it pretty effectively. And part of that is innovation in our state bureaucracy. Yes, I just said innovation in state bureaucracy. Yes, okay? Because of the way that the state was able to conduct outreach to reach those qualified and eligible families to get them enrolled in Medicaid. So that's number 2. And here's number 3, real quick. We need to think about healthcare access and capacity. Senator, you were part of a great bipartisan effort. Delegate Summers, where are you? You were as well. Just not this past session, but the session before, West Virginia became probably, about the 25th, 30th state or so to adopt legislation that expanded the scope of practice of advanced practice registered nurses. I can tell you from my vantage point, and I know the senator would, I think, agree, is that there was a lot of information out there. There was a lot of data out there that was presented to try to encourage and allow West Virginia to look at increasing its capacity, not by making new investments, but by reforming regulation. And that this had broad bipartisan support, but it wasn't accepted overnight. It wasn't accepted overnight, and both sides had to compromise. So many of the solutions and answers that we have are ones that we can find by working with the federal government, finding innovation within our own state administrative practices, and working together, for example, with the APRN bill to expand scope of practice, which, by the way, not only was economically efficient, we would hope, but also clearly is aimed at providing more care for kids and others, not only here in Morgantown per se, but most importantly in the rural parts of our state. And it reminds us of something that the National Conference of State Legislatures said about the CHIP program, and it's a real legacy of CHIP. And it's something that Justice Louis Brandeis said back in the 1920s. Justice Louis Brandeis said that the states are the laboratories of democracy. The National Council of Legislatures, state legislatures for CHIP said that the states are the incubators of the innovators for CHIP and for laboratory, innovative laboratories is what they called it. But let's keep that in mind.
I'd like to follow up on that question and maybe turn to Joan. And we've heard a lot about innovation. We've heard a lot about flexibility. We heard earlier kind of in the initial sort of birth of the CHIP program that how that interaction with Medicaid worked and the choice was given to states to make it a separate program or a combined program. So I want to ask Joan if you could maybe comment on, in your observations, how have states used these flexibilities to innovate and perhaps find efficiencies or find better ways to administer the program? And is there anything at stake going forward in that regard?
Yeah, well, I'll say a couple things. So, as Sarah mentioned, states could choose in CHIP to expand their Medicaid eligibility, or they could choose to run a separate state program, or they could choose to do a combination, actually. And that is, in fact, what the majority of states did. We have seen a trend over the past few years because the Affordable Care Act moved kids who are 6 to 18, who were between 100 and 138% of poverty. They moved those kids out of separate CHIP into Medicaid because you had a situation where you could have siblings and the younger child would be in Medicaid and their older sibling would be in CHIP, and they had to go to different providers, and that made no sense. So the Affordable Care Act sort of streamlined out that eligibility, and now those kids, they still get a CHIP matching dollar, but they're in Medicaid. So as a result of that, and the fact that California, which is a pretty large state, decided to move its entire separate state CHIP program into Medicaid, you now have a situation where the majority of children who are CHIP financed are actually in the Medicaid program. So that's been a shift over the past couple of years. And I think it speaks to going forward how important it is to think about these programs together. We should never talk about CHIP without talking about Medicaid and vice versa. They work together. In some cases, they are the same program. And CHIP has driven not only streamlining in the eligibility procedures, the enrollment procedures that we've been discussing, but also in thinking about, I think we're seeing some innovation on the Medicaid side with respect to value-based purchasing for children. New York has some really interesting work going on there. The reality is that children are not driving costs in the Medicaid program, and so they don't tend to get a lot of attention. And to the extent that there is delivery system reform, it doesn't really focus on children, by and large. That's why this New York work is particularly exciting, because it is focused on children. And we have a couple blogs up about it, so we could send that around. But I think the other point I wanted to make is that something I've observed over the last, 10 years, is that, which I think is a really good thing, is that people working in the children's community understand more and more that we cannot think about children in the absence of their parents and caregivers. And this was something I've really noticed a real change from a variety of perspectives on this since I started working on these issues. A lot of times you'd see, we don't want to talk about the parents, they're less sort of politically palatable, everybody loves kids. And I think there's just a growing realization that you just cannot do that. You cannot separate the child from the parent and the caregiver. And I'll give you a couple of examples. I mean, there's maternal depression. The rate of maternal depression for infants living in poverty is over 50%. It is epidemic. And we know how important developmentally that first year of life is. And if you have a mom who's depressed, that is a big problem. So this is why this issue of Medicaid expansion itself in West Virginia, you're very lucky that you got in on that early, because these kinds of connections, we have to start thinking about families holistically, or I don't think we're going to make progress.
Thank you. Maybe I'd like to turn to Dr. Moffitt for a minute, and then I have one last question, and then we'll open up for Q&A. We've talked a lot about access, and we've talked a little bit about kind of communities and the life outside the four walls of the healthcare system. I wonder if you can comment on that as well, just from your perspective as a clinician. What kinds of connections should we be thinking about in terms of improving health, improving outcomes for kids and their families?
Oh, that could be a whole summit that we could talk about. But I think that what we have to remember is our children don't all fit in one category. Our kids come from all over, and I had a little map that I looked at, because we were going to have slides, but then we didn't want to bore you. But our team, our CF team, made a map of where our patients come from, and except for maybe the very edge of Kentucky and really down on maybe the Virginia border, all the rest of the counties are covered for where my patients that I see with cystic fibrosis come from, and also Ohio and Pennsylvania. So it's a very diverse group, and they come from a long way. They have a big drive. And we've been trying to work on, so we've been mentioning mental health, so I got a grant to hire a mental health coordinator, and we're working on having our mental health coordinator go out in the community and then see what are the barriers. What are those? I'm going to read your report. You know, what are the barriers in Appalachia? Why do families not want to talk about issues? And yet we know depression is as high as 50%, and in our CF population with chronic disease, actually anxiety is a little higher than depression, but they're both there. And so these are very real issues that I can imagine where they come from, but I don't really know. So we partner with schools. So for kids, it's really, really important where kids are. And I tell you, our school nurses are wonderful. And we partner together so that they help us with therapies and things in schools. But I think we need more of that in terms of understanding. As a clinician, I think understanding the community these kids are in, where they are in their day-to-day. I mean, I'm seeing them their visits are long, but usually 4 times a year. That's maybe 12 hours in a year, unless they get admitted, and then I get to see them a lot more. But where are they the whole rest of the time? So I think that we as a group and the infrastructure that's already there, we can partner a little better in terms of understanding what's there in the community and how can we help our kids.
Okay, I have one last question, then we want to hear from the audience. So Senator Prezioso raised the importance of decisions that are made at the federal level in terms of what happens here in the state. And of course, we know this was a very well-timed summit, and the Senate Finance Committee just this morning held a hearing on the CHIP program. And from reports that I've gotten, at least, the opening statements from Senator Hatch and others certainly expressed a desire for bipartisan progress on this issue. So what I would like to do now is kind of turn to where are we with the reauthorization of the CHIP program? What does the timing look like? How does that affect states? And I'd like to turn to Joan for some comments on that, and then if others would like to jump in, that would be great.
Sure. So it's very unfortunate that I frequently get asked to prognosticate about what's going to happen in Washington. I don't think that's fair anymore, but I'll try. And also, for those of you that I chatted with at the reception last night, I was in a very positive mood, and I said, "Oh yes, I think we're going to get it done by September 30th." So everybody knows the funding is running out September 30th. That doesn't mean that all states are running out of funding September 30th, but it does mean that federal funding is ending. Unfortunately, I'm a lot less optimistic as of the last 12 to 20 hours since the reception last night, because this deal that's moving through with the debt relief and the hurricane relief does not extend CHIP. It's a 3-month extension, to keep government running, but CHIP is not in there. Which is really too bad, because what that means is that CHIP is going to have to run as a standalone health bill, most likely, because there's not a lot of other must-pass coming now in September before CHIP's expiration date. So now there's this whole other issue, which we could spend more time on, but there's always this chance that the repeal of the ACA and replace effort might reemerge. We heard earlier Senator Murray, Senator Alexander are having a hearing today. There is definitely work going on around market stabilization funds. It's possible something could emerge under the reconciliation process, which only requires 51 votes, but that has to happen by September 30th. I don't think that's very likely. There's some Medicaid issues there we won't get into. But I guess the bottom line is I'm more pessimistic today than I was yesterday about them extending CHIP by September 30th. That doesn't mean that I don't think they're going to extend CHIP. I think they are. There really is strong bipartisan support for CHIP. We see the committee staffs on both sides, I think, have been having really good conversations. The key issues will be how long is the extension? What is the match rate? Because we've had a bump up in the match rate of 23% percentage points as a result of the ACA. And what happens with a provision called the maintenance of effort? The maintenance of effort is currently in place through 2019. It says states cannot lower their income eligibility levels. The reason that was put in there is because why mess with success? That's what I call it, the MOA, why mess with success provision. We're doing well for children. People could see that as the ACA was implemented, it would take some time to get the marketplace up and running. And indeed, it would probably face a few bumps in the road, as it did. And so the thinking was, we're going to leave the kids where they are because they're doing well. So we don't want to mess that up. So that is still in the law till 2019. Whether that continues, I think probably is a question of what happens with the match rate. Those two issues are very closely linked because you can't, if you're going to lower the match rate, it would be hard to require states to keep those kids in there. I think it would be very problematic to move kids to the marketplace right now for a number of reasons. We've done studies, others have done studies. The coverage is just not as good as CHIP. I mean, it's very, very clear the cost sharing is going to be much higher, and I think that would be a mistake. But anyway, we do face, and I encourage you to think about this, I'm very worried about nothing happening before September 30th, and I think that is a big problem for states. And I'll tell you why. Most states have some extra money. The Kaiser Family Foundation just put a new report out yesterday. MacPac, of which Sharon was one of our favorite commissioners, has done this research as well. Kaiser just updated the research, and there are 10 states that will run out by December. Well, that's pretty soon, December. So if you're running out by December, you have to already start winding down your program. You have to send notices out to your families to tell them that they might lose their coverage. That is a very scary thing. And if you run your program through managed care, which most states do, how are you going to do contracts when you have no idea when the funding's coming, what the matching rate is going to be, and what you're going to be able to offer? This is no way to run a program. There's no certainty for states. There's no certainty for families. It's a big problem. And Kaiser also, in their report that came out yesterday, I believe 47 of the 49 states they interviewed in their larger budget survey have assumed full funding of CHIP with the 23% bump. So that is the vast majority of states in their budgets have assumed that's coming. So if it doesn't, then they have a deficit. That's a problem. And we have a number of states that I think have particular problems. Arizona, for example, which just reopened its program last year, they have a clause saying if federal funding is diminished, they're immediately going to close enrollment. I know you have a provision in your state statute. Maybe, Senator, you could comment on this that says if federal funding goes down, that you have to close enrollment. There's just lots and lots of questions here as to what's going to happen on October 1st if Congress doesn't act. So we need to be asking those questions. We need to be educating about the need for this to happen because children's coverage is not something we should be gambling with. Again, I do think they will do it. I think they'll do it by the end of the year, but I'm very worried they won't do it by September 30th, and we need to really raise our voices.
Think about this morning and the senator's video. Think about CHIP as being an insurance program for the ACA. This is exactly what Joan has just said, that CHIP in large part was aimed at trying to help smooth the rough spots in the ACA. And that need is still there. I'm a political scientist. Over the last year or so, we've proved that we're not really good at foretelling the future, okay? And, but I can tell you this, I think that we do look to the past. And the Senator, you've said this as well, that once something is established like CHIP, it's going to be very, very difficult to take that back, to walk it back. It's embedded. And Joan, I think what you've said is really important. This is an issue that deals with children's health. It's an issue that deals with families. It's an issue that deals with kids. But quite frankly, it's also an economic issue. When we talk about publicly funded insurance programs, we have to understand that the beneficiaries of those public insurance programs are not simply the children and the families, absolutely crucial, but it's our healthcare infrastructure. And these sorts of changes will be very disruptive on an economic basis as well. So, again, I think we look to the past, we hope for bipartisanship, and we recognize that once public policies become embedded and they haven't truly failed, it's very difficult to walk them back.
Okay, well, we have time for maybe a couple of questions. So I see the gentleman right, is that Dr. Neal? Go ahead, and there's a mic.
So thank you. Senator Prezioso has talked about the mismatch between revenue and costs that are increasingly confronting our state. The single biggest contributor to chronic health disease and chronic cost for health care in our state are obesity-related comorbidities. We rank, as you know, just about worst in the nation year after year in that regard. One of the biggest contributors to obesity is excessive sugar consumption. What do you think our chances are for enacting a POP tax, which I know is resisted strongly by the industry and so forth, but after all was responsible for building this four-year school of medicine quite a few years ago under the strong leadership of Governor Patterson, who enacted and the legislature enacted a POP tax. Can you comment on that, please, Roman?
I think that it will be better in the next session than it wasn't in this session, due to the fact that we still don't know where the deficits are going to come. We're going to have some revenues. Again, it's a strong lobbying effort. You know, you got to get beyond that, and it will be a battle. I'll just say that. I can't make a prediction on that one.
Any other questions? There in the back.
So thank the panelists. So I'm going to, I guess, walk the crazy plank here, but I'm pretty militant on healthcare as a right for all, which seems sort of the rest of the planet is on board, and that would include actually your eyes and your teeth as well. They're in your body. So can the panel comment on sort of the groundswell that seems to be coming from people on Medicare for all and a single payer system, and the resistance that there seems to be for our elected officials to kind of figure out how to make that happen as sort of the rest of the industrialized nations have?
I'll just make a couple comments on that, and then others should jump in. So I've been working in Washington on healthcare issues for about maybe 25 years now, and I actually did my graduate work in Europe. So I came to it, you know, thinking, oh yes, why are we the only advanced industrialized democracy that doesn't have a single payer? And it's interesting that just over the past year, the Affordable Care Act itself has gotten so much more popular, and you have seen, I think, a shift in public opinion about healthcare as a right. However, when you have the current lineup of control of all three branches of government, it's not going to happen anytime soon at all, I don't think. And I think one of the things I worry about, I think it's really important to articulate healthcare is a right, but I worry about energy being diverted from the fact that it was 100 years to get the Affordable Care Act. Senator Rockefeller can probably speak to this. It literally took 100 years to get health reform that moved us down the path of universal coverage. And you can see what a fight this has been, what a battle this has been. And the Medicaid program itself, the Medicaid program serves 74 million people now. And you could see from what happened this year, the effort to cap Medicaid, which is not part of the Affordable Care Act, that was sort of the holy grail for Speaker Ryan and some others. So the Medicaid program itself is very vulnerable. So we have to balance these things while continuing to articulate the vision, but also recognizing that we have to keep working to improve where we are now, because this is a monumental achievement to flip the vision of the country to people should have coverage rather than we're going to carry this large load of uninsured people, if that makes sense.
I'm going to kind of slightly follow up on that question and kind of ask the panel to wrap it up with maybe a little bit of a sort of final words, and we just have a couple of minutes. And I want to go back to actually Clay Marsh's opening comments and this concept of purpose. And Clay, you talked about kind of business overriding the purpose, and sometimes, I wonder if we've also sometimes let politics override the purpose, and maybe sometimes even the policy process kind of override the purpose. And I wonder if, you could all comment on, is there an opportunity right now? We've obviously spent the last 8 years kind of arguing about one policy, which is a big policy, of course, the Affordable Care Act. But is there an opportunity to talk about sort of principles and the purpose as opposed to what the policy should be? It seems that perhaps there's an opportunity, but I wanted to get your thoughts on that.
In many ways, we're taught to create categories and to separate things out rather than look for similarities. I look across this room today, and I know that there's people here from the private sector, there's people here from state agencies, people here from academia, people here from nonprofit groups, foundations, advocacy groups, you name it. We've talked a lot today about building a coalition for policy change, haven't we? But you know what? We also build coalitions for policy implementation. I want to come back to CHIP one more time, because I do think that CHIP is an example that we can use to understand how public policy is developed and how it's implemented. And in its implementation, we know that there have been coalitions of individuals, some formal, some informal, aimed at getting word out and getting people connected to health care insurance and access. It's not always a smooth road. It can be quite bumpy. There can be friction. I'm going to mention two people that I think a lot of people in this room know, Sally Richardson and Tom Haywood. And years ago, they were given the task, along with others, to help to develop a health insurance strategy for covering the uninsured in West Virginia. And I always remember Tom Haywood saying that you have to look at this as pieces of a pie. We really can't have a single-payer system or Medicare for all. It's a product of our history. As Atul Gawande says, we're path dependent. But we can chip away at this in small pieces. And very much that's what we've done. And so I would just like to summarize by saying, always remember, it's not only about coalitions for action, it's also about coalitions for implementation. And looking around this room, I know of so many people who've been involved in that.
I'm not sure my own opinion, I wish we would, this is my pie in the sky, that we would have one single payer. I think it would make the whole thing a whole lot easier. How come we're not having these debates about Medicare? Because adults advocate for adults, and AARP and all the others, I don't know who they all are. And yet we're having these debates over and over about CHIP, about Medicaid, and so we are the ones in the room here, and I'm proud to say I'm a part of it, but so we need to keep advocating. And I don't know where it's going to go, but I have to say, I think all of us who are seeing our pediatric patients, I don't look to see what insurance they have. The only time I know what it is, or if they don't have it, which actually it's very rare now today, and it wasn't that way a few years ago. So I'm proud that it's that kids have insurance, but when it's when we get a roadblock in access to getting something, and then they can't get something, or it's too expensive, or what do we do? And then there's where we spend a lot of our efforts, much more than we ever did when I started out years ago. And that's too bad that we use a lot of our healthcare efforts trying to get through the system and getting access in these authorizations, prior authorizations. And we got to make that more streamlined. So maybe we're not going to have a single payer system, but we got to make it more efficient and work better so that we can do what we want to do, which is what I want to do, is continue to care for kids, which is what all the providers do in this room, only then we have to have many more people help us to do that. So it saddens me, though, that there's not a Medicare debate, but boy, there sure is about getting rid of Medicaid. And that's sad, and that shouldn't be the way it is.
Does anyone else want to comment? Senator? You don't have to. We're actually a little over time.
Well, I probably shouldn't go down this road, but I am. You know, you've got to take money out of politics. There's dark money, big money, corporate money. People hardly run on their own merit anymore. They hire a media consultant to go out and invent them. I've been in 8 House races, 8 Senate races, and I had to go out and hire a media consultant for my last election so they can redefine me. So, you know, it doesn't make sense where we're going in politics, where people can't get up and express their true beliefs, not some corporate interest or somebody that's, you know, handing you a campaign check. And that's been a lot of problems. And I see it now on the state level, where the dark money is coming in, controlling elections and things of that sort. And I don't think you get the true message out when people control elections. And that's probably all I should say about that.
Well, we are out of time, but if I will just kind of add one of my takeaways from this whole day, which is maybe we should add another P word to purpose, which is persistence. And clearly, problems do not solve themselves overnight. It takes a lot of time to build up an idea, to enact it, to implement it, and then to continue improving upon it. And then, of course, to sort of navigate all the changes that happen both internally and externally. So I think persistence is important, and you know, I'm so struck by the dedication and persistence of all the people in this room who really take on that problem-solving perspective and really focus on the results. And I think that's really something to be commended. So thank all of you, and please thank our panel.